Welcome, everybody, to the Amplify Long-Term Care podcast. This is Frances Nahas, your host. I am super excited to be here today with Rob Leffler. Rob, why don't you introduce yourself?
Thank you very much. I'm delighted to be here. My name is Rob Leffler. I'm the Vice President of Clinical Services for Synchrony Pharmacy. Synchrony Pharmacy is a long-term care pharmacy based out of Louisville, Kentucky. We have a variety of pharmacies in a few different states that service about 30,000 patients in 16 states.
And how did you get into pharmacy?
I've always been passionate about long-term care. So I was exposed a little bit to long-term care in college, and a consultant pharmacist actually came in and spoke to a professional practice class, and I was like, that sounds really interesting. And something I would really like to get involved in, and was not able to find a job right out of college in consulting. And so I went and worked at a hospital for a little while. And a few years later, I had done a certificate program through Purdue University and went and interviewed for a consulting pharmacist position and had a great conversation with the manager at that pharmacy. And he looked at me and he said, I really enjoyed our conversation, but I'm really looking for someone that has experience. And I looked him in the eye and I said, well, there's only one way you can get experience.
True statement.
And he loved that I said that, and he hired me. And so he and I worked at a variety of long-term care pharmacies actually together, which ultimately brought me to Synchrony Pharmacy to lead the clinical team here.
That's fantastic. What do you love about long-term care pharmacy?
It's different every day. No 2 days are the same, especially out in consulting. You go to a different facility and it's a different dynamic. It's a different group of people. It's a different set of needs. And just in reviewing patient charts, every patient is different. Every patient has a different set of comorbidities and a different set of goals and a different set of desires. And anything that I feel like I can do to improve people's quality of life appeals to me.
Yeah. What do you wish, because you're in the facilities a lot, right? You spend a lot of time with patients in the facilities. Is that right?
I used to.
Okay.
I used to do that a lot. And I also helped run long-term care pharmacies. And so I kind of walked both sides of that fence for most of my career. My current role is to work directly with our consultant pharmacists that actually go out to the facilities and do the chart reviews, and the nurses that go out and do auditing for us.
I think that's still going to lend itself to my question, which is, what do you wish folks working in the long-term care pharmacies understood or thought about being in the facilities? Like what insights do you get from being in the facilities that you wish more pharmacists would bring back?
Yeah, that's a great question. The first thing that came to mind is, and I think that this is something we always try to drive home as an organization, but it's patients that we're taking care of. And it's different than a community pharmacy because, we're in a building that's locked and we don't see the patients and we don't even talk to the patients most of the time. When we're dispensing inside the pharmacy, we're talking to the nurse or maybe the director of nursing, and they're calling because they need a refill or they've got a new patient or whatever that might be. But as the consultant, you get that interaction with the people that are actually hands-on caring for those patients, and you see them in the hallway and they become more real to you. One way that we as an organization have tried to bring that into our dispensing operations is we have pictures of actual patients all over the pharmacy. Even in the home office area, it's them doing different activities and, of course, with permission and everything. But it just kind of keeps us centered and grounded and focused on what matters.
That's really important. Yeah. What trends do you see happening now in sort of the patient population or things that pharmacists should be thinking about in the long-term care space?
I've been in long-term care a long time.
Yeah.
And, I think we all say it all the time, but patients are sicker when they get to us. It's a higher acuity than we've seen in the past. There's a lot of focus on value-based care, which There's always been that, but it's tied more to their financials now. And so that kind of changes the mentality of the staff and the leadership in facilities a little bit, I think. But I think it's that higher acuity. It's helping people age gracefully in place and trying to help them maintain that quality of life.
Great. How do you think about, there's lots of sort of clinical topics on that often come up. So how we think about fall risks in long-term care facilities, or dementia as, a particular type of disease state that's pretty common in long-term care facilities. Anything that you want to highlight or touch on about particular areas that we should be thinking about?
Absolutely. So let's start with falls.
Yeah.
We, as an organization under Synchrony Health Services, we have a pharmacy, but we also have rehab services. So physical therapy, occupational therapy, speech language. Yep. And as an organization, we developed an interdisciplinary falls program to layer on top of the falls programs that facilities already have. Just falls are a huge costs to facilities. It costs, according to McKnight's a few years ago, they said it was about $5,200 per fall to a facility. And obviously that impacts patients too. How many patients do we discharge to the hospital that don't even come back to our facilities because of whatever happens beyond that fall? So decreasing that fall risk is one passion of mine. So we as an organization, look at each and every fall for one of our largest customers and do a pharmacist review of their medications, looking at PRN use the 72 hours before their fall, make recommendations to the facilities for changes in therapy to decrease that fall risk. I think going along with fall risk, that sometimes we fall into a pitfall of, okay, so this patient fell and it was because they got up in the middle of the night to use the restroom and they didn't use their walker. Right. Case closed. We know that it's just this patient safety awareness, and if we can encourage them to use their walker, then they're not going to fall.
Right.
Well, it's a lot more complicated than that because there's so many different factors that can come into play with a fall. And so I, as a clinician, not only think about this fall, but are there changes in their medication profile that I can recommend that will decrease the risk of a future fall? Because that first fall, no matter what caused it, increases that patient's risk of falling again. And so maybe they're on a medication that's highly sedating or highly anticholinergic. And if we can make a change in that medication, even though this particular fall had to do with that walker and doesn't really have anything to do with medicine, I can still have an impact on that patient.
Right. That's great. Anything, so as you think of sort of the pharmacists in a long-term care pharmacy, that they should advocate for with their facilities to help address that, or things that they can be doing?
So I think one of the big things, and I've experienced this throughout my career, is you go in and you review patient charts, and you might happen to see that a patient fell 2 or 3 weeks ago, and nobody ever let me know.
Interesting.
It's encouraging that communication from the consultant pharmacist to the facility, and building that relationship with the director of nursing, with the administrator, with the unit managers, with the nurses on the floor, so that when something happens, they think, oh, I should let Rob know that. That might be something valuable for him to know. Because I think, there's always opportunities and there's always things that we find to make recommendations for. But if you tell me that Mrs. Smith has this issue, or I think this could be an adverse drug reaction to a medication, that gives me something to focus on. That gives me something to think about, that I can make a recommendation to make an impact on her that's going to be valuable to that patient, and not just something that I randomly discover reviewing that chart.
That reminder sometimes, if we think of things as being like, well, if it's not specifically related to the drug, then it's not related to the drug, versus saying like, look, lots of things that can happen might be related to the drug, and it's worth asking the pharmacist and the expert in the drug, versus just making the assumption that, the fall, or it's unrelated to the medication, right? It seems like it might be, but Yeah.
And there's a lot of things that are related to medications, like you talk about, that people don't think about.
Yeah.
I mentioned, I think I said this, but anticholinergic medications, they can induce or increase dementia. And a lot of us as pharmacists know that, but facilities don't necessarily think about that. And so if there's a change in a patient's mental capacity, their memory, and maybe there's been some recent medication changes, because it's not always the obvious choices. It's not always going to be the Benadryls, the oxybutynin of the pharmaceutical world that are causing increases in that confusion. It can be a combination of 2 or 3 different meds that have a low anticholinergic burden. And if we can think about our alternatives to some of those, we can help those patients a lot.
That's really cool. Are there other things like that where you would say, hey, make sure you're talking to facilities around these types of things and that you're getting this type of information as you review medications for patients?
I think any kind of significant change, those changes in condition, I think there's, the facilities are going to communicate those to the prescriber.
Yep.
But if there was a mechanism for them to effectively communicate it with the consultant pharmacist too, to your therapy team, to your dietitian, thinking about that whole interdisciplinary team of experts that you pull together, that you use, that are part of your team. I think sometimes with going into a facility once a month, or whatever that frequency might be, depending on level of care and contracting and all those things. But it can sometimes be a little out of sight, out of mind.
Yeah.
And so, if I happen to be at the facility and someone falls, I'm there. And so they think about talking to you about it. But the day after you're there, I think it's easy for them to not think about communicating those significant changes.
Interesting. Yeah. Yeah. Talk to me about deprescribing, which might be a kind of counterintuitive thing for pharmacy, but
I think a lot of people think about it as counterintuitive, especially as you think of it as a business. But it's a huge topic in long-term care right now. The American Medical Directors Association has this whole drive to deprescribe partnership with the American Society of Consultant Pharmacists. And it's something that we've embraced as part of what we do as far as consultants are concerned for some time. It's about making sure that patients are on the right medications, the right doses, and not on duplicate therapies or therapies that maybe aren't necessary anymore. I like to think about right prescribing kind of through that same frame, because sometimes it's not always taking medications away, but maybe changing medication A to medication B because the risks aren't as significant, but still treating something that needs to be treated. But there's also opportunities for, patients change. They change over time. Their needs change over time. And so what was prescribed for them 10 years ago, 5 years ago, even 3 years ago may not still be what is necessary for that patient.
Right.
You think about medications that are metabolized and in the aging process maybe metabolized different because of their kidney function. Maybe the dosing just needs to be decreased, would be an example too of deprescribing lower dose.
Right. Of the same medication, but bring the dosage down. Super interesting. So what do you view kind of the overall role of a consultant pharmacist? We maybe should have started there, but I jumped right into the heavy hitting topics.
So, we talked about a lot of things that the consultant pharmacists do, but, the primary or one of the big functions of the consultant pharmacist is regulatory wise. They have to review every skilled chart at a facility, regardless of length of stay for that patient. And so, the role of the consultant pharmacist is to come in and to look at each resident in a skilled nursing facility through that pharmacy lens and think about, okay, so what medications are they taking? What comorbidities do they have? How are we monitoring these medications? Are we adjusting these medications appropriately for their age or their renal function or their hepatic function? A lot of different things. And then it's some problem solver and detective work. There's patients that maybe they're having behaviors or they're becoming more reclusive. And how can we make recommendations to impact those social impacts of life in a long-term care facility?
Yeah. What advice would you give to somebody starting out as back in the day when you're like, the only way I can get experience is to get experience? What advice would you give to a pharmacist who's in that situation today?
That's a good question. I think my advice would be don't give up, for one. So I applied for a consulting position when I first, was getting out of school, found one in, it was in the dark ages. So it was in the newspaper, found, in an ad, which, nobody does that anymore. You don't find a job in a newspaper anymore, but, keep trying. And I think, there's ways in as well. It may not be that immediately you get into consulting if that's what you want to do and you're clinically driven and that's what your desire is. There's a lot of pharmacist positions in long-term care. We have a lot of operations pharmacists, and we have moved people from operations into consulting, knowing that eventually they wanted to get into consulting. If you have the flexibility to move, we've had pharmacists that really wanted to do consulting and could live anywhere. And so then when we had a position open, they knew we had built a relationship with a young pharmacist that really wanted to do consulting, but we didn't have a position at the time. And when one opened up, she was willing to move to Ohio to get into consulting.
Nice. How would you contrast, the time you spent working in a hospital pharmacy versus kind of the consulting pharmacy world? This is me being super curious because I did a lot with hospital pharmacies back in the day. You? Yeah.
I really liked, it was a small-ish pharmacy or hospital in Indianapolis, Indiana, probably 350 beds or so, not huge, but not tiny. I really enjoyed that experience. I think it really helped kind of cement some clinical skills for me before going into clinical work in nursing homes. I think you see a lot of similar patients because there's a lot of older patients in hospitals. I mean, we had a couple of floors where they were almost all geriatric, but then also it gave me some exposure to some things that in long-term care you don't always get a lot of exposure to. And I specifically think of like intravenous medications. And so, as part of regular work, sometimes you'd be assigned to work in the IV room. And while we have an IV room and we service patients on IVs and either hydration or antibiotics or CPNs or whatever, you don't get a lot of exposure all at once to that.
Right.
And so by going through the hospital and learning all that, even a number of years later, I still have those resources in the back of my mind to be able to say, okay, well, this is how we can handle this and be able to help with that.
Great. And it's one of the riskier areas of pharmacy, truthfully. So, yeah.
It is.
What are your thoughts on pharmacogenetics? Sort of a new emerging part of the industry.
Yeah. So we became exposed to pharmacogenetics and pharmacogenomics about 6 or 7 years ago and started to dip our toe into that. And I think it's fascinating. I think I'm surprised with what I know about it that we haven't seen it grow more than we have. You see a lot of vendors and there's a lot of labs that are constantly reaching out to me saying that they, are interested in being a pharmacogenomic partner to us. And we've had a specific partner. We've used a couple of different companies along the way, but we've had a partnership with a lab for 7 years or so. And it's really this kind of untapped resource. It's not something that everybody necessarily needs. For any of your listeners that don't know what pharmacogenomics is, it's, the science of determining who's a fast metabolizer versus a slow metabolizer or a normal metabolizer. And that's not going to apply to every medication, but it can help us determine maybe someone's going to be more prone to side effects with one medication than another. With some of the psychoactive medications, it may help us predict who's going to respond well to an antipsychotic. We had a great anecdote that we had a patient that his means of communicating with the nursing staff was to run into them with his wheelchair.
Oh, jeez.
So when he wanted attention, he knew how to get it.
Right.
He would just bang into them and was fairly nonverbal, a lot of behavior issues. And we had done a pharmacogenomic test at the doctor's response to our recommendation to do one, changed his antipsychotic, and the consultant pharmacist went back about 45 days after a change in the medication and was talking to one of the nurses and said, I remember we did a pharmacogenomic test on one of your patients and we changed an antipsychotic. Whatever happened with that? And the nurse said, that's him sitting over there in his wheelchair talking to the nurse at the cart. So, is every story that we have with having done a pharmacogenomic test like that? No. But knowing that we can have that kind of effect on patients' lives is very meaningful to me.
That's fantastic. What would you, it's kind of a great rounding out question, what advice would you give to patients or to family members of patients as they think about sort of aging, moving into a long-term care facility? You see, we started off the conversation right with there's just higher acuity and there's more medications in a lot of cases. And so what advice would you give to the family members and the patients?
I think my biggest piece of advice would be, don't be afraid to ask questions. I see it a lot. I feel like there's a lot of patients that, they go and see the doctor or they're in a nursing home and everything happens around them and to them and don't ask questions. Their family doesn't ask questions. And so just to not be afraid to ask those questions, to not, make sure that you understand what's going on, not make sure you understand why are we starting a new
why
medication.
is always a great one. Yeah.
I think a lot of society focuses on the what, and it's important to understand the why, because there's a reason, but sometimes asking that why question gives other people an opportunity to think about it from a variety of points of view that may impact care.
No, it's a great one. And I see it where, I think a lot we just have a tremendous amount of trust in clinicians to start with. And so you don't sort of want to question. And I think for most clinicians, you see it all day long, you do it all day long. So you kind of forget to explain, right? For the patient, it might be the first time they're ever experiencing that type of thing. And it's very rote for, the physicians and the nurses and the pharmacists. And so it's kind of encouraging that step back and say, hey, it's fair to say, explain to me why. Explain to me why.
Now we've lived this life in long-term care for those of us that have been in it for a long time, and it's right here, and it's what we live, and it's what we know. And when your loved one, your parent, goes into a nursing home, it's foreign for a lot of people. They may not have had that experience, and so not being afraid to ask questions is a valuable skill to have.
Yeah, I think probably in a lot of parts of life, but especially this one.
Not just long-term care.
Right. Tell us a little bit more about Synchrony as an organization. Where can we find you?
So it's Synchrony Health Services. We do have several different branches of our operation. I work in the pharmacy division. We also have a rehab division, which is Synchrony Rehab. We didn't talk about this, but we also have a lab, which is somewhat unique.
Yeah.
It's unique enough that we have pharmacy and lab, or pharmacy and rehab, but to also have lab services. We discovered through working with our customers that there was a need for lab services in long-term care, that the opportunities in various areas were decreasing for them to have a strong partner in a lab. So we opened a lab here in Louisville, Kentucky, which is where our home office is and where I'm located. But we have pharmacies throughout the Midwest, in North Carolina, Iowa, Florida, and we service about 30,000 patients in 16 states from those different pharmacies. And then our rehab division, we have a lot of crossover, which is really nice because then we can do programs like our interdisciplinary falls program, where a pharmacist does a review and a therapist does a review. With our lab, we've had a lot of opportunity to get good information about antibiograms, which aren't always available to us as pharmacists in long-term care. So it's been a unique opportunity for me to work for a company that has so many different divisions.
That's fantastic. Yeah. So I'll do kind of a selfish plug. But for folks who found this conversation interesting, tell us a little bit about the class you're going to teach at the Amplify Long-Term Care Conference this summer.
I'm going to talk about I-SNIPs. So it's coming. If you don't have partners that are in it, we've got long-term care facilities that are participating in I-SNIPs. We've got facilities that are going to buy into and be in part owner in an I-SNIP.
I'm gonna ask the dumb question for our audience. For somebody else out there is thinking it. What's an I-SNIP?
So it's like Medicare C. So it's like Medicare Advantage. So they're being reimbursed by Medicare for patient care, and it's a value-based care process. And so it's for patients that are in facilities longer than 90 days. It's not that short-term Med A stay. It's beyond that. And so there's different levels of risk that a facility can take. So they can have their facilities enroll in an external I-SNP, or they can have their own I-SNP, but that increases their risk because you're getting paid to take care of these patients. You're being paid to keep them well. So, thinking about what goes along with that. But the framework for my talk is going to be not only some basics about what I-SNPs and I-SNPs are, but also how can pharmacies partner with facilities to be a valuable vendor to them and help support them as they all start to go more and more down this value-based care path.
Yeah, it is one of the things that's, having been in healthcare for a long time now, always amazes me that we talk about value-based care a ton, and yet there's such a disconnect in a lot of places between the physician and nursing provider side and the pharmacy side. And you really have to bring them together to do value-based care well.
Right. And with it being tied to reimbursement, it's going to become more and more important, which is exciting.
Yeah, fantastic. Well, this has been a very fun conversation. Thank you very much. And for folks who want to hear more from Rob Leffler, come see us at the Amplify Long-Term Care Conference in just about a few weeks by the time this airs. So great.
Thank you very much.
Thank you so much. Thanks for being with us today, everybody. This is our pharmacy podcast for long-term care. You can find us on YouTube, Spotify, or Apple Podcasts. Please subscribe and continue to listen for great conversations around long-term care and how to elevate your pharmacy.